Chapter 7, Cardiovascular and Respiratory Anatomy and Physiology. This chapter summarizes cardiovascular and respiratory anatomy and physiology, both in conditions of rest and in response to exercise, both acute and chronic, so that appropriate and effective exercise programs can be designed. A clear understanding of basic cardiovascular and respiratory anatomy and physiology is critical for providing an appropriate strength and conditioning program. The functions of the cardiovascular and respiratory system are to provide and maintain an optimal environment for cellular function. Within this chapter are anatomical and physiological descriptions of the heart, blood vessels, and lungs. In addition, the response of both the cardiovascular and respiratory systems to acute and chronic aerobic resistance exercise. Are identified. Upon completion of this chapter, the reader should be able to recognize and understand the impact of aerobic and resistance exercise on the cardiovascular and respiratory systems. Cardiovascular anatomy and physiology. The primary roles of the cardiovascular system are to transport nutrients and remove waste products while assisting with maintaining the environment for all the body's functions. The cardiovascular system plays key roles in the regulation of the body's acid-base system, fluids, and temperature, as well as a variety of other physiological functions. The anatomy and physiology of the heart and of the blood vessels are described in this section. The heart. The heart is a muscular organ that in reality is two interconnected but separate pumps. The right side of the heart pumps blood through the lungs, and the left side of the heart pumps the blood through the rest of the body. Each pump has two chambers, an atrium and a ventricle. The right and left atria function primarily as blood reservoirs, delivering blood into the right and left ventricles. The right and left ventricles supply the main force for moving the blood through the pulmonary and the peripheral circulatory, respectively. Valves. The tricuspid valve and mitral bicuspid valve, collectively called atrioventricular AV valves, prevent the flow of blood from the ventricles back into the atrial during ventricular contraction, systole. The aortic valve and pulmonary valve, collectively the semilunar valves, prevent the backflow from the aorta and pulmonary arteries into the ventricle during ventricular relaxation. Diastole. Each valve opens and closes passively. That is, each closes with a backward pressure gradient pushes blood back against it, opening when a forward pressure gradient forces blood into the forward direction. The thin AV valves require almost no backflow for closure, whereas the much thicker semilunar valves require stronger backflow. Conduction system. A specialized electrical conduction system controls the mechanical contraction of the heart. The conduction system comprises the synaesthetic node, SA node, the intrinsic pacemaker, where rhythm electrical impulses are normally initiated, the internodal pathways that conduct the impulse from the SA node to the atrioventricular AV node, the AV node, where the impulse is delayed slightly before passing into the ventricles, the atrioventricular AV bundle, which conducts the impulse to the ventricles, and the left and right bundle branches, which further divide into the Purkinje fibers and conduct impulses to all parts of the ventricles. The SA node is a small area of specialized muscle tissue located in the upper lateral wall of the right atrium. The fibers of the node are continuous with the muscle fibers of the atrium, with the result that each electrical impulse that begins in the SA node normally spreads immediately into the atria. The conductive system is organized so that the impulse does not travel into the ventriculars too rapidly, allowing time for the atria to conduct and empty blood into the ventricles before ventricular contraction begins. Figure 7.3. It is primarily the AV node and its associated conductive fibers that delay each impulse entering the ventricles. The AV node is located in the posterior septal wall of the right atrium. The left and right bundle branches lead from the AV bundle into the ventricles. Except for their initial portion, where they penetrate the AV barrier, these conductive fibers have functional characteristics quite opposite those of the AV nodal fibers. They are large and transmit impulses at a much higher velocity than the AV nodal fibers, because these fibers give way to the Purkinje fibers, which more completely penetrate the ventricles. The impulse travels quicker through the entire ventricular system and causes both ventricles to contract at approximately the same time. The SA node normally controls heart rhythmicity, because its discharge rate is considerably greater, 60 to 80 times a minute, than that of either the AV node, 40 to 60, or the ventricular fibers, 15 to 40. Each time the SA node discharges, its impulse is conducted through the AV node and the ventricular fibers, discharging their excitable membranes. Thus, these potentially self-excitatory tissues are discharged before self-excitation actually occurs. The inherent rhythmicity and conduction properties of the myocardium, heart muscle, are influenced by the cardiovascular center of the medulla, which transmits signals to the heart through the sympathetic nervous system and parasympathetic nervous system, both of which are components of the autonomic nervous system. The atria are supplied with a large number of both sympathetic and parasympathetic neurons, whereas the ventriculars receive sympathetic fibers almost exclusively. Stimulation of the sympathetic nerves accelerates depolarization of the SA node, the chronotropic effect, which causes the heart to beat faster. Stimulation of the parasympathetic nervous system slows the heart rate of the SA node discharge, which slows the heart rate. The resting heart rate normally ranges between 60 and 100 BPM. Fewer than 60 is called bradycardia, and more than 100 beats is tachycardia. Electrocardiogram. The electrical activity of the heart can be recorded at the surface of the body. A graphic representation of this activity is called an electrocardiogram, ECG. A normal electrocardiogram seen in this figure 7.4 is composed of a P wave, a QRS complex. The QRS complex is often three separate waves, the Q wave, R wave, and an S wave, and the T wave. The P wave and the QRS complex are recordings of electrical depolarization, that is, the electrical stimulus that leads to mechanical contraction. Depolarization is the reversal of the membrane electrical potential, whereas the normally negative potential inside the membrane becomes slightly positive and the outside becomes slightly negative. The P wave is generated by the changes in the electrical potential of cardiac muscle cells that depolarize the atria and result in atrial contraction. The QRS complex is generated by the electrical potential that depolarizes the ventricles as a result in ventricular contraction. In contrast, the T wave is caused by the electrical potential generated as the ventricles recover from the state of depolarization. This process, called repolarization, occurs in ventricular muscle shortly after depolarization. Although atrial and repolarization occur as well, its wave formation usually occurs during the time of ventricular depolarization and is thus masked by the QRS complex.